Let's talk about myths in medicine. The third myth, number 3, is built on myth number 1. Remember when we talked about the morphine and the giving morphine for patients with acute abdomen because we know what they have? Now, there is a myth that is very controversial. Anybody who is trained in medicine, he is told by his attendings, I'm talking about internal medicine, he's told by his attendings to not give lopressor for sinus tachycardia. You know, there's a lot of things that are good on their face value, but not good, not practical. So, for example, I'm not going to give lopressor for sinus tachycardia. Why? Why is that? It comes from the notion that sinus tachycardia, which is true, sinus tachycardia is not an intrinsic aberrant rhythm or abnormal rhythm of the heart. It's usually it is the heart compensation or reaction to a different stimulus or different condition. For example, if you have fever, you'll have tachycardia. If you lose blood, you're gonna have tachycardia. If you're hypovolemic, you're gonna have tachycardia. If you're anxious, you're gonna have tachycardia. All of these things, sinus tachycardia. And the idea is that if you treat this sinus tachycardia, you will mask the original condition, and you will miss the treatment for the original condition. All right, that is true, but it's not practical. In real life, we treat sinus tachycardia if you know the cause, right? Similar to the morphine. You give morphine for somebody with acute abdomen if you know the cause. If you don't know the cause, don't give it. Same thing here. If you don't know the cause and you're running around like idiots treating sinus tachycardia without actually thinking where they come from, then that you're gonna result in patient harm. So you're gonna know the cause. So, for example, I'll give you an example. Somebody who is in SIRS, he's having systemic inflammatory response syndrome, which was with a heart rate of 150. Now this guy is 70 years old. He's not gonna tolerate the 150 for too long. He's gonna have demand ischemia. He's gonna deteriorate into maybe other rhythms that could be more dangerous. You can't do that. You can't leave the patient. And of course, everything is not going to be done because the patient is tachycardic. You want to extubate the patient, you won't be able to extubate the patient. You want to wake the patient up from even doing SAT, just waking the patient up, you won't be able to do SAT because the patient is tachycardic. He's going to be more tachycardic when you wake him up, so you just keep him down. All of these things all depend on you are an ideologue. You don't want to treat the sinus tachycardia because you've been told so. You didn't think about it. If I take that sinus tachycardia and rule out everything, the patient is not bleeding, the patient is not septic, the patient is not XY, okay, and it's only SIRS. Okay, what are we going to do? It's going to take its time. There's no way. SIRS is a systemic inflammatory response syndrome. There's no treatment for it. You just have to wait until it's gone, right? So just treat it. Treat it so everything else goes along with it and the patient doesn't get injured, right? For example, if you have sinus tachycardia related to GI bleed, for example, right? If you give lopressor or anything to treat the sinus tachycardia, beta blocker to treat the sinus tachycardia, you will have hypotension. The blood pressure will drop, right? So it's not like it's gonna go unnoticed. It's just you look like an idiot. And of course, when we do that, that's why I say when you treat sinus tachycardia in ICU, you use IV lopressor. So even if you look like an idiot, you only look like an idiot for 4 hours. You don't look like an idiot for a day. Okay, so that's just a little trick on the side. For example, another example, somebody who is a DTer. Okay, so he's having DTs. Is tachycardic and hypertensive for that reason. We give him so much Valium that he is zonked. He can't even protect his airway. He's like completely zonked like this, but he's still tachycardic and hypertensive. And don't tell me you haven't seen that. We have seen it. You've seen it, right? What are you gonna do? You're gonna treat. We know that tachycardia is from DTs. right? That's the sympathetic response to DTs. It's not it's nothing that's going to be hurtful to the patient. The brain, or the conscious part of the brain, is not active. It's already asleep with the Valium, but the sympathetic part is difficult to control. So control it. Give him. That's why we give clonidine sometimes. It works on both, and lopressor is acceptable in this situation once you know that you are the sedation of the patient is correct. Now, some idiots take that as a sign that the patient needs more benzos, so they give him more benzos. And what happened to when they give the benzos? The patient gets intubated because the patient was asleep already, and he's on the edge of losing his control over breathing. Even he's gonna become apneic, and you give him benzos, then he's gonna become completely apneic or aspirate. So you don't treat sinus tachycardia in this situation with benzos. You treat it with lopressor. That's why we have to treat the sinus tachycardia if we know the cause. And thank you.